Very much. I'm Peter Chiodini, Italian grandfather to account for that name, and it's my pleasure to be scheme organizer for UK POCT Parasitology and a great opportunity to speak to you all today. So I need to do a bit of explaining about the title. Why have I called it What a Dipstick? Well, just in case we have delegates who are not used to British television, there was a very famous TV series called Only Fools and Horses, which later became a musical. And in the phrase, Del Boy, the chap you'll see on the right here, says to his younger brother Rodney, calls him what a dipstick. I had to look it up. I didn't know what this meant, but the BBC has a convenient dictionary that tells you. So you can decode this program, and a dipstick means a fool. So that's why it's called what a dipstick. And of course, dipsticks are the colloquial name for rapid diagnostic tests. Right. What are we dealing with humans? We have really six if you allow for the subspecies of Plasmodium ovale, species of malaria parasites that infect humans. Now, this is what we're trying to avoid. This is a blood film here with Plasmodium falciparum at a high parasitemia. That's the thin film. And this is the thick film with the parasite still seen against a background of stroma from lyse red blood cells. And these are white cells, as you will know. This is what it does. These are cerebral capillaries, which are completely full of schizonts of Plasmodium falciparum that are stuck to the capillaries. They obstruct it, cause local acidosis, coma, and in this case, death. That's what we're trying to avoid. We're all in the game of good diagnostics to avoid anything like this ever happening. Now, there was a sea change in 2010. The World Health Organization decreed that there should no longer be syndromic diagnosis. That's really medical term for guesswork. Someone comes in with a fever in the malarious area, and if you say it's malaria on that basis, you're going to be wrong probably half of the time at least, because fever has got many, many causes. So WHO said in 2010, parasitological diagnosis, that means blood film or dipstick or something else. Now, in most areas we use EDTA blood for this, and we need it within the laboratory within an hour before the morphology starts to deteriorate. And those of you that are hematologists will be very well aware of this. So what are the options when we have the blood sample? We can do a blood film, you've seen those, a rapid diagnostic test, lateral flow assay or dipstick, or molecular methods, which are PCR or the LAMP assay, which is an isothermal nucleic acid amplification test. Now, this is the crucial slide. If you want to take away one thing from this, think on these critical parasitemia points. Parasites per microliter or percentage parasitemia, and what it means clinically. If you've got 100,000 parasites per microliter of your blood, that's an awfully high level, as you can imagine. That's 2% of your red cells infected. If you've got that, you're going to get intravenous treatment. You've got 200, that's the level at which we assessed the dipsticks for the WHO product testing scheme, and I'll come to that in a moment. That's 0.004% parasitemia. The best microscopist, my best microscopist in the malaria reference lab will get down to 5 parasites per microliter, 0.301%, and none of us will do better than that. And sometimes, if it's a busy day, it might be 20 parasites per microliter, but that's still very good clinically. DNA-based PCR, 2 parasites per microliter, and look at this RNA-based assays, 1,000-fold better in terms of limit of detection, 0.60, 0.704% parasitemia. So here today we're talking about the rapid diagnostic test, the dipsticks here. They came in 1990. I went to that Congress, and a colleague of mine, an eminent malariologist, said, Peter, look at this. These are great. These are dipsticks. They're going to transform malaria diagnostics. I got back to London. I said to one of my lab staff at the time, and they said, nah, this will never catch on. This will be blood films forever. I thought, well, as it turned out, more than 200 million are now purchased each year, and there are various brands available. Now, since COVID, I don't have to explain what a rapid diagnostic or lateral flow test is anymore. But the principle is this, it's antigen capture. So antibody on the nitrocellulose strip that traps the malarial antigen, detecting antibody that's conjugated to colloidal gold usually. So it's a sandwich, and you get a line there on the strip. And then this one at the end is an antibody to the type of antibody that's used for the detection that traps it. So you need the this stripe to make sure the test has worked, and that stripe to tell you if there's malarial antigen in it or not. So far so good, but there's always a but, isn't there? What's the antigens we detect? Histidine-rich protein 2, which is Plasmodium falciparum only, important to remember that. Lactate dehydrogenase, present in all the malaria parasites, is a glycolytic enzyme, so you'd imagine it would be. And aldolase, similarly, glycolytic enzyme, part of the same system. Some devices will detect falciparum only, others will detect falciparum and pan, some will do falciparum, pan and vivax, but not many of those. Now, they can fail. Why might they fail? Poor technique. You don't always get the blood in the well. It's not as easy as doing a COVID test. Low parasitemia, you saw the limit of detection for molecular or indeed blood film is lower. Not enough antigen, too much antigen, or you've got a duff product. WHO was so worried about this that it introduced product testing. And we started this in 2008 and finished it in 2018 and assessed manufacturers' products against standardized malarial samples to see how good they were. This was my lab in London at the Hospital for Tropical Diseases. That's the CDC in Atlanta and Chin Cheng's lab in Queensland. And samples from all those red dots came to us in London, Atlanta and Queensland, and we assessed them. We measured the antigen levels in my lab in London. We then tested the parasites against them. This is parasite detection score. This is 200 parasites per microliter, 2000 parasites per microliter. So if you're going to buy at this end where they're high performance. You're not going to buy this one because there's a lot of false positives in there. So 75% of you, if I'd use that one on you, would have malaria even if you'd never been near a malarial area. So there were mergers and acquisitions. And the same with falciparum. But then we hit problems. We were testing some samples from Peru that was supposed to be P. falciparum, and Sophie Jones, who subsequently went on to work at CDC, said, Peter, these samples are weird. They've got no antigen in, but they're supposed to be falciparum. And I said, well, repeat it. We repeated it, and they were not. And that's because they'd got gene deletions for HRP2 and 3. This is important if you're thinking of using these products. Where are the gene deletions? Well, Peru, this is Peru, as in the weird Peru samples, but look at Sudan and Eritrea, and I'll come to that in a moment. WHO recommends not to use HRP2 based dipsticks where the prevalence of deletions is greater than 5%, which means you're then stuck with using different types of RDTs or microscopy or molecular methods, which is not a runner in the rural tropics. So Eritrea switched. Eritrea switched 2006. It had problems, changed to a different one in 2016, and had to go with 2 in the end to get decent coverage in 2018. So it has implications for finance, and also, at the end of the day, we're here for the patients for clinical care. Now, here's an example that we got in London. Sudanese lady attended A&E. She'd back from visiting her Sudan. She thought she had malaria. She was right. The CareStart RDT said it was negative for P. falciparum, that's the HRP2 line, but positive for PAN. So it's referred to us for confirmation of suspected P. vivax. What did we get? The CareStart and Binax, both HRP2 were negative. Optimal, which was LDH, positive. And so the PAN genus on those others was also positive. Genotyping, negative for the HRP2 and HRP3 genes. Here's another one. Somali heritage male, attends A&E, thought he had malaria. Hospital test negative for malaria. Binax positive for PAN only. So they said, well, maybe this is P. vivax. But what we got was P. falciparum with greater than 20% parasitemia. So here we got, when we tested it, we diluted it down and got a clear positive, and with this one the same. So this is basically a prozone type effect. There were genes present. So strictly speaking, you call it a pososome because that means antigen excess, but most people called it a prosome-like effect. So we had other cases where cases were missed. Gene deletion here, 3 with gene deletions, 1 with prosome-like, and 1 because it was a low parasitemia. So you're beginning to think, I hope, that they're not perfect, these, and you need to be careful where you use them. And would you use them in a situation of near-patient testing? Do they detect P. knowlesi? Well, HRP never should, because HRP2 is only falciparum. Aldolase can, because it's pan-specific, but may miss low parasitemias. And similarly, LDH may get confused with the Vivax or falciparum. So we sent one out in NEQUAS. CareStart did quite well. It called them either non-falciparum or 1 falciparum, and missed none of them. But this one here, the non-falciparum line picked up some, but also some were negative. So the bottom line is knowlesi is not reliably detected by all RDTs. So where do we go from here? Last few slides. Well, first of all, we have British Society of Haematology guidelines on when you should use them or not. And basically, it's clear that we're still relying on microscopy, and the RDTs are supplementary tests. And basically, you should be in EQA schemes, and we have that for the RDTs. And here's the critical thing. British Society of Haematology says you don't recommend using the RDTs in place of microscopy in the UK. You might get false positive with rheumatoid factor. They're less sensitive than expert microscopists. You might get positive after treatment if it's HRP2. And also, apart from falciparum and Vivax, you can't tell the species or the parasitemia. Operator misunderstanding can happen. We talked about knowlesi and so on. So at the end of the day, in the tropics, they're a credible threat to malaria control, the RDT failures, but they're still enormously valuable because they give malaria diagnosis to people who otherwise wouldn't have it. But in where we're practicing, over-reliance on these is an avoidable risk. We don't have to use them, but we can, and we do. The point is, using them alone is hazardous. You still need good blood film microscopy and wider use of molecular platforms. We now have hospitals that widely use molecular diagnostics for malaria. So
I will be talking about rapid testing of respiratory, gastrointestinal, and sexually transmitted pathogens, and mainly concentrating on challenges and very briefly mentioning the benefits more as an introduction, really. So as we all know, point of care testing of infectious pathogens has many benefits. So the first one obviously is that you get really rapid results, which means that you can have very timely care pathway decisions. And that could be prescription of antiviral medication, or it could just be that if you're able to confirm a self-limiting virus that is unlikely to be very harmful, you can release the patient for home care. And it has been shown to reduce the use of antibiotics. And somewhat more specific to infectious pathogens, you can use them in a variety of environments, which means it's a really good means of supporting infection control. And this would be if you have an outbreak or a pandemic scenario, but also for endemic diseases. And we'll be talking about sexually transmitted infections in this presentation. So when it comes to challenges, we will be focusing on 2. And these are very much what we see from an EQA provider point of view. So first, it is understanding test analytes, and second, understanding the sensitivity and specificity of the assays that you are using. First, understanding test analytes, and again, from the perspective of an EQA provider. So we see this quite a lot with serology assays and in our serology EQA schemes, that our participants are not always able to distinguish between antigen and antibody. And if they know they're testing for antibody, they are not always able to distinguish between IgM, IgG, and total antibody. An immediate effect, of course, is that if you're reporting EQA results, you might get into trouble, and this might also impact your performance rating. So the example here is our syphilis serology EQA scheme. So this is not a scheme that is specifically tailored for point-of-care testing users. This is more geared towards diagnostic laboratories, even though we do provide a separate result category for reagent testing, which is quite a common rapid test. But we do ask quite a lot of our participants. So we ask them to distinguish their results based on assay type. So you have reagent, you have TP agglutination, but you also have screening assays, immunoassays, and confirmatory assays, immunoblots or line assays. And then they also do need to know, are they testing for IgG and total antibody, or are they testing for IgM? And if you're using a point of care assay and all you can see is syphilis reactive or non-reactive, then this obviously can be quite confusing. And we have seen that because we do get more and more point of care test users in our schemes. But the answer here is that if you are experiencing this, if you're not quite sure how to report, where to report, get in touch with us. If you provide us with kit information, kit insert, even better, then we'll be able to give you quite detailed instructions on how exactly to report your results. But this is not only important from sort of point of view of participating in an EQA scheme. This does have real impact on testing patients as well. And an example here is HIV serology. So I hope you can see my mouse. So there are several markers of HIV infection. So the first one you have coming up is HIV RNA. The second one, this kind of a yellow brownish line, that's the HIV P24 antigen. And last, after about 3 weeks from infection, you have the anti-HIV antibodies. So first bump you see here in blue that's the IgM. And then this section is already IgG becoming more prevalent. And not all assays and not all serology assays can detect all of those markers. So we're going to be focusing on serology only. And if you're using a third generation assay, then what you can detect is the antibodies against HIV. So IgM and IgG. But as you can see, these have quite a late onset. So these images on the right are just from our in-house testing. If you're using a fourth generation assay, you will be able to also pick up the P24 antigen, which is an earlier marker. And again, depending on the assay used, but some assays also actually allow you to distinguish. So here you can see on the top, this is the control. The middle band, this is the antigen signal or lack thereof on the right-hand side. And at the bottom, you have the antibodies. About 5 years ago, we sent out a specimen in our HIV point of care, which is specific to point of care assays and point of care testing users. And that was a specimen that was only positive for P24 antigen, and it was negative for HIV antibodies. And it was always intended to be educational because we knew that we have a lot of participants who are using third generation assays, and they are not able to identify this as HIV reactive. And we're not here to penalize anybody, we're not here to score people down. We just wanted to raise awareness about this profile. But what surprised us was that we actually saw, and this is highlighted here in this red box, that we had participants who were using fourth generation assays, and they were still not able to identify the specimen as HIV reactive. It is a bit hard to unpick. Could be many reasons here. It could be that actually the participants had changed their assays and they did not inform us of the change. So they were maybe actually using third generation assays. But it is possible, and that is a lot more worrying, is that these participants did not recognize this profile as being HIV reactive. And it is true that it is quite a rare specimen to see, because the time window where you only have antigen come up and not the antibody is quite small. So it could be that they just did not recognize what they were seeing, those users. So it is really, really important that you understand what you are testing for, exactly what analytes are included, because the accurate interpretation of your results does rely on you understanding your assay. So now we're moving on to sensitivity and specificity. And as we all know, every assay has a unique sensitivity and specificity profile. And if you have an assay that has multiple targets in it, sensitivity and specificity often vary according to target. And it also varies according to assay type. So if you have nucleic acid detection assays, they are usually really, really sensitive. If you're using lateral flow devices, they are usually not as sensitive. But I guess a really sort of important thing to consider is that there is no universal sensitivity and specificity target. Your assay just needs to be fit for the very specific purpose that you have in your setting. And that is what you need to ensure. So first, we're going to sort of talk about sensitivity and specificity using our sort of enteric viruses EQA scheme. This is a very busy slide, but really the take-home message here is just one. So if you have a patient positive for either rota, noro, or adenovirus, and they are symptomatic, then you can expect a very, very high viral load in those stool samples. So here's an example from our viral gastroenteritis EQA scheme. And the sample in question is positive for norovirus genogroup G1. And as you can see in the middle panel here, so these are all participants who are using nucleic acid detection assays. And by and large, none of them have any issues detecting virus in the sample. You have a few who've gotten a false negative, but could be operator error. Now, if you look at the results for participants who are using antigen detection assays, you get very mixed results. And you can see that some assays, for example, Immunocard here or the RigaQuick Combi assay, everybody who's using this assay have identified the virus. And then you have other assays where you see that none of them have been able to pick it up. And also it does sort of, it makes analysis a bit harder. We do have those general terms, so like our biopharm, other, RigaQuick. So these are participants who are not giving us full assay details. So this is probably a mixed group. So these participants are very likely actually using different assays. And you can also see that the results are a bit more split. But you can see that definitely some assays are more sensitive than other assays. And even for us, the in-house assay that we use is a lot less sensitive for norovirus genogroup 1 than it is for norovirus genogroup 2. Of course, genogroup 2 is the more prevalent one, but this is something that if you're using an assay, you really need to be quite aware of these limitations. Now, the next example from the same scheme, this represents a simulated sample from an infant who has loose stool and distress 4 days after receiving the rotavirus vaccine. And the sample was positive for rotavirus and the vaccine strain, so G1P8. And it is known that some patients who receive some of the rotavirus vaccines, they can shed rotavirus at a very low level. And this sample was indeed meant to represent that occasion. So as you can see, not surprisingly, if you're using a nucleic detection assay, you can pick up these very, very low levels of virus. Most of the participants were able to do that. But those who were using antigen detection assays largely did not pick up the virus. And the ones who did, I actually question. I think that might have been maybe swapping specimens or some sort of operator error. But in this case, actually, increased sensitivity may not be that useful because this was really very low levels of virus. So yes, you might be able to get that positive result from nucleic acid detection. But if the baby is seriously unwell, then that is perhaps unlikely to be relevant for that. And it might just prove to sort of muddy the waters if you're able to pick up very trace levels of something. And the final example, this is a snapshot. It's just one specimen, but of course it does represent a trend that we see. And it is true that we see a lot more false positives for participants who use nucleic detection assays in comparison to participants who use antigen detection assays. Not necessarily down to poor specificity, it could be just contamination, it could be operator error, but just a trend that we do definitely see. So as always, you know, sensitivity, specificity, you know, your assay needs to work for your setting. There is no standard to one, you know, more sensitive is not necessarily better. All assays have limitations. So now we hop over briefly to respiratory viruses. And again, the take-home message from this slide is that by and large, the viral load that you would expect from a respiratory sample is a lot lower than what you would expect in a stool sample for enteric viruses. Of course, it depends on the virus. It really depends on the individual. It might depend on the age of the patient as well. But in general, this is something you should be aware of. And also, onset of symptoms very often is sooner than peak viral load. So this example is from our respiratory viruses EQA, and again using RSV as an example. And here you can see, again, nucleic acid detection assays can easily identify virus, whereas antigen detection assays do struggle. And when it comes to sort of those assays for respiratory viruses, you do have to be very careful with the assay you're using, because a lot of them are very clear that they should only be used for confirming infection. They should never be used to rule out infection with any virus. Now, the last assay type that I'm going to cover is the rapid plasma reagent test. So this is meant for screening for active syphilis infection. But what is interesting about this test is that when you are using this assay, you're not testing for the pathogen, and you're not testing for antibodies against the pathogen. What you are testing for is something that probably occurs because of infection with the pathogen. So you're actually testing for antibodies that are produced against substances, for example, cardiolipin, which are released by cells that are damaged by infection with Treponema pallidum. And this is an agglutination assay. So results are visually determined based on antigen-antibody complex formation. And just for those of you who are not familiar with this assay, so again, this is our in-house testing results. So on the left, you can see the controls. You have positive control, negative, and also weak positive. And on the right-hand side, you have the samples. Now, if you have very clearly positive samples like 5 and 6, you're not going to have any issues interpreting those results. Sample 4 as well is quite clearly positive. But when it comes to sample 1, 2, and 3, which are all negative samples, these can be more difficult. I mean, squint and you might see a weak positive there. When it comes to performance of this assay, so as I said, it is only meant to sort of test for active infection. So if you have a sample here that represents acute infection, IgM positive and IgG positive, most of the participants have no problem. They report it as reagent positive. But the real limitation of this assay comes when you are testing samples that are either negative or which perhaps represent a past infection. So we have an example here. So it's a past infection sample, IgM negative, IgG positive. And more than 20% of the participants have actually reported this as reagent positive, even though it is negative. And you can see that it's not associated with any particular method. You have split results across all assays used. So this is most likely due to individual interpretation of results than anything to do with the assay. In summary, it is really important to understand the detection limits of your assay, and especially the lower detection limits. If there are any potential issues around specificity, you really need to be aware of that. And how you use your assay or how your assay is applied really should be informed by the limitations of your assay. And continuous monitoring of assay performance is crucial. So I actually did pop this here because we got that question in the first webinar and we got it again today. And this is not meant to be like a definitive answer, but I have come across this really, really nice sort of guidance in literature. So I'm not going to talk through it. I just popped it in here because I thought it might be useful to some of you. But this is a very nice risk-based approach. So you can read the, the references all there. You can read it at your leisure, but just popped it in hoping that it might be useful.